Fure, and I am a first-year pharmacy resident at Abbott Northwestern Hospital here in Minneapolis. And today I'm just going to be discussing a little bit about my project, looking at the impact of guideline-recommended antibiotic selection in our acute COPD exacerbation patients and how this affects outcomes within our larger community health system. And I would like to just briefly acknowledge my project preceptors, our infectious disease specialists here at Abbott, Emily Herstein, Delaney Hart, and Krista Gens, who have been helping as well in the project. So looking at our objectives for the study, we're looking specifically within the Allina health system, and we analyzed some data collected with looking through the outcomes associated with these acute COPD exacerbations and how appropriate antibiotic therapy selection based on our current in-house institutional guidelines can impact these outcomes. So just a little bit of background here. So acute COPD exacerbations are really associated with some increase in local and systemic inflammation. And there are a lot of different pathophysiologies involved with these exacerbations. But one of the primary things that we do start to think about is if it is a bacteria pathogen causing this inflammation. Typically, these organisms will be ones that are already colonizing the respiratory tract. So these would include strep pneumo, Haemophilus influenza, and Moraxella catarrhalis. And these are usually going to be our most commonly isolated bacteria. So when we're thinking about antibiotic selection, typically agents that are going to be targeting these organisms are what we've kind of predetermined within our institutional guidelines for appropriate therapy. So looking at the GOLD criteria, the most recent 2024 guideline for the recommendation for antibiotics in these patients would be including patients that have met the criteria for the 3 cardinal symptoms. So increased sputum volume, sputum purulence, and then increased dyspnea. And patients would then meet the criteria for antibiotics if they had all 3 of these. However, if they had only 2 of the symptoms and increased sputum purulence was one of the 2 present, or the patient is requiring mechanical ventilation, these would also be criteria for requiring antibiotics. And the GOLD guidelines do also call out, so the benefit of antibiotics when they are indicated in patients have been shown to shorten their recovery time, lead to a reduction in treatment failure, lower risk of early relapse, and also decrease their hospitalization duration. So this was a retrospective observational study that we're currently conducting with the primary endpoint looking at the length of hospital stay in hours, and our secondary endpoint looking at all-cause 30-day readmission rates, all-cause 30-day COPD-related readmissions, and then also looking at the percentage of patients that are requiring a change in antibiotics, specifically broadening their therapy. So when determining the sample size, we conducted a priority power analysis to establish an N number of 208 patients to be included in this study. And this was based off of some similar studies that have been conducted in the past and also looking at our current length of stay for acute COPD exacerbation patients within the Allina healthcare system. So right now, our average length of stay is around 68 hours, or averaging out to 2.8 days. One of the studies that I looked at had observed a 22% change in patients' length of stay when they had gotten azithromycin versus a beta-lactam antibiotic for acute COPD exacerbations. So extrapolating these results, we had expected to see around a 20% change in length of stay between patients receiving appropriate versus non-appropriate first-line antibiotic therapy. And then to determine the standard deviation, this was also extrapolated from 2 studies that I had looked at with similar outcomes, and they had done a standard deviation from around 2.1 up to 3 days. So this led to our anticipated 36-hour standard deviation used in the calculation. Our inclusion criteria was patients that were 18 and older who were admitted within the Allina health system between September 1st of 2023 and 2024. They had to have a diagnosis of acute COPD exacerbation, meeting the diagnosis code, and then they had to receive either a first-line antibiotic which we define as doxycycline, augmentin, or levofloxacin per our inpatient acute COPD clinical pathway recommendations, or they had to receive a non-appropriate first-line antibiotic, which would be anything other than the above listed as first-line antibiotic therapy. Our exclusion criteria were patients that were admitted to the ICU or transferred within 24 hours of their admission, if they were requiring a non-invasive mechanical ventilation, or they had some other predisposing bacterial infection, such as a pneumonia, or a secondary diagnosis of a pneumothorax or PE, if their respiratory culture was growing Pseudomonas, or the patient has a history of severe underlying pulmonary disease, specifically cystic fibrosis, active tuberculosis, or lung cancer. And then patients that would not be indicated for antibiotics. So this we did as patients that had a documented dry or non-productive cough, as they would not be having increased sputum volume or sputum purulence to meet that GOLD 2024 guideline criteria. Results for the study are currently undergoing. We are still in the process of data collection and are getting some of our results kind of as we speak. So we'll hopefully have some great results to be sharing at the MSHP conference, and very excited to have those results to you. Here are my references so far. Thank you so much for consideration.